what I would like to try to present to you is moving from a definition of what is surveillance, trying to see what is surveillance for, the role of surveillance in the public health system, presenting also some practical example, discussing from my international experience, and particularly from the experience of Italy, that is quite pragmatic from my standpoint of view. And the third part of the presentation will be instead about the social determinants, and particularly health inequality and surveillance, because as we will see, it's an important tool from my point of view to tackle health inequalities. So let's start from the very beginning, and luckily the very beginning start from the town in which I live, and it's not my research. This is a research that has been published by some other person, not Venetian, not even Italian, and that found the root of surveillance back in the 14th century, and it was in 1348 when the Venetian Republic that was very interested about trade, as you all know, and but also about health in some way, because only with sufficient health they could have all the trade with the globe. And so it's interesting enough, the first surveillance activity, it has been a kind of a global health surveillance, because the central role of Venice and all the traffic that was at that time. Then moving on quite rapidly, we come to this continent, and particularly Rhode Island colony in 1741 approved an act to require taverns to report contagious disease among their customers. This is nice also as historical fact, but also as the idea of surveillance. It's not necessarily linked to only hospitals and other places, but a good example of surveillance involves the territory, and it's local, as topo. Okay, and then, but systematic happened only in the 19th century, first in Europe and then in the US. But we have to wait until the 1968 with the World Health Assembly to have a definition of surveillance that is not only linked to infectious disease. Because until that point, surveillance was only surveillance of infectious diseases. So it has been in that World Health Assembly that started what was called at that time epidemiological surveillance, that is a slightly broader concept, and that in a few years then it has been named after public health surveillance. So public health surveillance is, here you can find a definition from WHO, but if you get around the CDC, American CDC definition is very similar to this one. Let's try to read this together, and I've tried to emphasize what are, from my point of view, the measure aspect of surveillance. So it's a continuous systematic collection, analysis, and interpretation of the health-related data needed for the planning, implementation, and evaluation of public health practice. Such surveillance can serve as an early warning system for impeding public health emergencies. And this way, the link with the infectious disease surveillance is very strong. But there is more. Document the impact of the intervention or track progress towards specific goals. And third, monitor and clarify the epidemiology of health problems to allow priorities to be set and to inform public health policy and strategies. So also with this broad definition, we find some characteristic of surveillance to be continuous and systematic, And then what is surveillance for? So it is an early warning, but it's not only warning. It's something else, is linked to the action, so the health practice. And this link should be clear. And today we will talk of a specific kind of surveillance, because this applies to any kind of surveillance. And it could be applied for surveillance of diseases. It could be applied to surveillance of injuries. But we will talk today about this specific surveillance that is internationally called behavioral risk factor surveillance. And why? Why this peculiar surveillance came out? Well, it has been after the recognition of NCDs as the major challenge for public health. I'm pretty sure that with this audience, it's useless to remind how important in terms of mortality and morbidity are NCDs. In both now developing and developed countries. So it's not only a Westerner problem, it's a global problem. And but after recognizing this important, what it has been widely recognized is as a risk factor, more than in any other health problem, are the most or the more attackable targets. So working on risk factor, we can really tackle NCDs, or at least a big part of NCDs. That's why it became so important to have information about risk factors. So started what's it called, behavioral risk factor surveillance, or quite often behavioral risk factor surveillance system, and as a fundamental information system for NCDs and what? And health promotion. Why health promotion? Because health promotion is the approach to modify, to help the country's citizen in having solving problem related to risk factor. Then historically, the surveillance was based mainly only on risk factor, but now most of the surveillance systems are collecting information useful for any intervention on health promotion and a lot of intervention on public health. So also not only information about smoking, alcohol, the big four that's common in all surveillance system, alcohol, smoking, and physical activity and diet, but also information about attitude, information about access to services. Why? Because it's this, I go back, is this great link to action that the surveillance system should inform. So it's not only the prevalence of risk factor, but it's also information that could help the action of the public health action, and more specifically, the health promotion action. And let me say that on this, surveillance is quite unique, because for health promotion, you do not have so many information tools. If you think when you're dealing with diseases, there are a lot of information around from hospitals, from medical records, and other sources of information. Morbidity, mortality, now it's common to have that kind of information. But what about health promotion? If you think, besides some specific research that is addressed to evaluate some specific intervention, we do not have too much of information to know if things are changing for the bad or for the good. So in this way, I see surveillance as a unique and important source of information to do what? To produce evidence. Because now I think it's time that we move our health promotion action to base our health promotion action on evidence that what we are doing is producing some relevant change. And this particularly in the time of crisis for which we all know that we have less and less money for health promotion and public health. So, but I think it should be clear that conditions stand for a behavioral risk factor surveillance system to be effective. And some are already in the definition, so if it's not continuous, if it's just data collection and not also analysis and interpretation, that's a limitation. But let's try to see all these characteristics one by one. Okay, must be systematic. And with systematic, as I told you, quite often we refer to behavioral risk factor surveillance system, just to emphasize that it is systematic. So one big question could be, what's the difference between a survey and a surveillance? And let me try to explain this using an example. I'm looking for, there must be in this room a smoke detector. I'm sure it's hidden somewhere, but there must be a smoke detector. And what do you want from a smoke detector? Well, that collect some data about smoking. But you want that these data are collected continuously. Not once a week, certainly. Not once a month, but continuously. But that's not enough. You want that the smoke detector is connected to some alarm. Do you remember the definition of surveillance? That was the first aspect, alarm. But not only, you want that that alarm is connected with the action, the fireman department or whatever system is. So with some person that could act, and this is nice, because to act, what the person in charge should do? Well, must analyze the data and interpret. That's the way we call this. So basically, it comes here and decide if it's an idiot that is smoking just below the smoking detector or a real fire. If it's a small fire, I get the extinguisher outside and just end the fire. And if it's a big fire, he or she will call the fireman department, and they will come. So it's I think this is a very nice and useful example to make you understand what's the difference between a survey and a surveillance. It's much more. So it's also a survey, a very peculiar survey, because it must be timely. Okay? So one survey every 10 years certainly is not timely. If we want to have information if, let's take smoking. We know smoking is fairly stable over time. It is decreasing in most of the countries, but there are not jumps. So perhaps you don't need to have weekly information about smoking. Still, you want to know if there are changes over time. For instance, we have experience in many countries that in some group of population, smoking is not decreasing, but it is increasing. Younger women, typically. So this is an important information. That's the alarm that must sound timely to act, to have action, particularly targeted to these groups. And of course, talking about smoking, the issue of social determinants and health inequality, it's a big issue, as you all know. I mean, I've seen data from all over the world, and particularly with smoking, the difference between social classes are humongous. And this is an important information if you want to act. Because probably if you spend money, I don't know about Canada, I know about Italy, they throw away an incredible amount of money with this public campaign that was unearned, because they were not targeted in the right way to the right person. Okay, and that's the evidence we need. That's the evidence we need to save money or to put money in the right programs. Anyway, this is timely. Okay, specific must be specific. And this is the link with action. We will see from example more clearly this. It cannot be just the prevalence. Quite often we already have this kind of information from the National Institute of Statistics or this kind of health survey that are carried out. But those kind of information quite often are very general. They are not specific. And specificity over the year, it has been clearer and clearer. The specificity means also to be local. Because the action, the public health action, the health promotion action is local. And so we need local information. And I'm very happy to give this talk just after what has happened yesterday, that in Montreal has been presented data that were local, that related to the 12 different sections of the island of Montreal. And last, but of course not the least, linked to action. And we will see from example how this happened. But to be linked to action, there is another condition that is important, also in defining how works a surveillance system, a good surveillance system. Again, I'm just importing from other discipline a definition, the definition of a learning system. A learning system can be seen as a spiral, something that is moving, but when it's coming back at a level that is higher when it started. And this is exactly what should happen in a surveillance system. You start from the knowledge you have. You know that smoke is bad, okay? And so you will ask some question about smoking and so forth. And so you collect data. You do your, and this is a circle as you all well know, analysis and interpretation. And this produces new knowledge that will inform your plans, your programs, your intervention. But quite often from this will come other knowledge need. One example, now we are working on a new, in Italy we have a 5-year prevention program. It's called prevention program, but it's a health promotion and prevention program. And now, after the WHO NCD action plan that you know that almost all the countries agreed on this action plan program with some targets 2020. And one of the targets, for instance, is on salt. Salt consumption, to diminish the salt consumption. We do not have in our system any question about salt. So what will happen? I can forecast what will happen. So this is knowledge that is coming not from inside, it's coming from outside. If there will be an objective on salt in the next 2014-2018 national prevention plan, we will have in our system a new question about salt that eventually will produce information useful to perhaps a replanning also what it has planned so far. That's the concept of a learning system. But and let me spend 2 words also about the systematic. So you can see that this is not just an office that collects data. That's the basic difference from what they do in the National Institute of Statistics. They're concerned about this process. Someone tells them to collect some data, and they do this nicely. And they're worried about precision and all this stuff. And I hope that they will continue to do that, because those kind of surveys are very useful. But we are talking about something else. Inside of the surveillance system, we must have persons that are collecting data, but we also must have persons that are capable of doing analysis, interpretation, and the dissemination process. And to bring the data to the decision maker at the national, regional, local level where data are needed. Sorry, I used the wrong word. Not data, but information. So data that are already interpreted to become real information, useful information for decision making. So let's try to see some example together. This is, as I mentioned, the oldest surveillance system that is still running. We are talking about millions of interviews so far, because they do collect something as 100,000 a year. So it started in 1984. It started as a federal system. And so at the beginning, not all the states were involved in the data collection. But over the year, it has been stable and produced more and more information. Let's talk about the use of information and the support for decision making. Obesity was not a big issue in the public health agenda, and generally in the health agenda in the US, until these maps were produced. And this, actually, they do have also a nice presentation of the maps and how the color changes over the year. And with this presentation had a huge impact, particularly on the media. Because as you can easily see here, for the sake of brevity, I've reported just 3 years, but it is nice to have the show 1 year after the other, and out from a general condition in the 90s, lower of 10% of obesity prevalence in the US. Already at the turning of the century, it was between 15–19% in most of the US, with some state that was going over the 20. And in only 10 years, they passed from 20 to 30 in most of the states. So this information, easily readable, has had an humongous impact. And obesity started to be one of the major targets in the US. And this came from the surveillance system. But another nice example, let's go down under. We are in South Australia, nice place. And this is surveillance system, slightly younger than the one that I presented, the American one. This started in 2002. And this is the analysis that we made just to see the effect of a public health campaign. And I want to show you this just to show you how useful it is to collect data continuously and not just 1 year and then another year or every 5 years. If you collect information every 5 years, you got only this point and this point. And it's difficult to say what has happened, okay? Instead, here we have all the history, okay? So this is the prevalence of those eating 5 serves of vegetable a day. So that's the target, the shared target, international target, to eat at least 5 serves a day. As you can see, also Australians are not so good. They were starting something as between 7 and 8%, and it was steady over time. So it was not changing. Then a big campaign, July 2005. What we have, wow, a jump, almost 3 times as much, more than twice. But that's typical of a public health campaign. If it's not sustained, the effect is temporary. So over the months, slowly, but the prevalence was going down, and probably it would have been at the same level of the beginning, if not a second campaign came with a lower effect, but the effect of stabilizing around 10%. So try to think to the amount of information we can get from this. First of all, public health campaigns are useful, but they must be reinforced, otherwise the effect is temporary. Second, not less important, there is an easy target here. Because if in July 2005 we passed from 7 to 16, well, this means that it's doable to have at least 10% more. And so this is a possible target for other action beside the public health campaign. So this is just to show you, but I will spend a bit more time in presenting the Italian system, not only because, of course, I know very well this system and I'm Italian, but because in some way I find it paradigmatic. It started later, but it started to learning from the experience of other countries. So it started only in 2007. And, now is one of the systems that perhaps is most embedded in the public health system. And I'll briefly show why and how. The system itself is called PASSI, that in Italian stand for Progressi nelle aziende sanitarie locali. So Italy is organized in 20 regions, and every region has got a different number of local health units, but the local health units are those that are responsible for the health of the citizen. It's in some way similar to the Canadian system in many ways. And the system started to be focused on the local health unit. That's the first interesting aspect. And started on this basis that information must be linked to action, and action must be linked to information. So the system itself started to be useful for the local, regional, national action. And here is the system. So you see how many people are involved. 1,100. It's a lot of people. Can you imagine how to train all these people in a single room if you want a national system? Impossible. But being a kind of federal system, we had a training of the regional responsible, and in every region, this person trained the person at the local health unit, and the person at the local health unit trained their team. So basically, it has been produced a positive infection of data. So interviews are collected at the level of local health unit by local health personnel. And this is quite unique around the globe, okay? This is quite unique around the globe, and it's quite unique, the performance. And from my experience, I've been working in several surveillance systems. This is only because of this. I cannot find other explanation. I mean, usually in Italy, as in Canada or in the US, you got a response rate that could range from 20% to 40% if you're lucky. For some research, it could be 50. 87. And the refusal is 9%. Because they receive a letter from the local health unit advising that someone would have called from the local health unit, and here the nurse that is calling. I end up looking for a single person, name and surname. That, of course, then are cancelled. But they are talking to a person, not to a number. Okay, so this is success, but the example of PASI is interesting. Particularly, I was telling you what's happening now with the new National Preventive Plan. The new one is based on the result of the surveillance system. Eventually, we do have indicators that are coming from the surveillance system, and targets are based, when I will be back to Italy, the same day actually, I will have a meeting with a panel expert for the Ministry of Health to set the standard for the targets based on the surveillance system. But then it can be useful then to monitor and eventually to evaluate. And this is both at national and regional level. Last 10 minutes, I would like to address the issue of inequalities. Of course, as many other information systems, surveillance can give you this kind of information. This is, what's that? Smoking habits, okay? So these no smoker are much higher in university level, and smoking is much higher instead among the less educated. And if you take instead of education, you take income, it's the same story, even worse in some way. So we are almost 40% among those that have a lot of economic difficulties, while there are only 25% with the group with no difficulty. But what's the news? We know already this. So what is surveillance for? Well, first of all, to have local information. That's great. I mean, when you will do the analysis at the local level, you will find out that disparities are not the same over the country. In some areas are much higher than in other, and this could help to A, address these disparities, B, understand why there are these disparities. And so the local aspect is useful to decide the program, and also very often how it should be carried out. Then I've just printed out, this is in Italian, but I just printed out this as something that we do regularly in the most known epidemiological journal in Italy. Just one slide is presented there, and then attached there is an article that tries to explain. So, very quickly, this is smoking over the years, the first 5 years of data collection. And you see the differences that you have seen among this is a low income class and the higher income class. Well, this is the sad story. These are stable over time. Instead, these are getting slightly better, so smoking is changing, but it's going down. So it was more than 30 in the middle class, and now is less than 30. It was 28, now is 25, 24 in the upper class, 23 actually. So this is a story. So basically, if you take the average, it's a success. Smoking is going down. But if you read this, this is bad news for public health, bad news for health promotion. So, few consideration about what is the challenge now. It remains critical to monitor social determinant of health. So this is one of the challenges that must be taken by surveillance system. And to have a good surveillance system that can help in understanding what is changing. Because if there will be time afterwards, I will show you. There are also some good news. It's not everything going for the bad. There are some success in which we have been successful in reducing social health disparities. But we must understand the success to then have more successful programs. The other big challenge is perhaps to collect also other information about social determinant of health, because we know that it's not only all income and education, it's also something else. And this is another big challenge that could be taken by surveillance itself or by our statisticians that can do some linkage with our data, with data that are produced elsewhere. I mean, I don't think that in surveillance system we should collect data about sidewalks, urban sprawls, or facility to get around your town with a bike. We already have those kind of information. So it's a matter of doing some ecological analysis, and once again, to be local. It's important because this allows you to do some ecological analysis and to link other social determinants to the inequalities that eventually are produced. So basically, we need resources on data collection, but also we need resources to do in-depth analysis, because now we should move from showing inequalities to showing and to understanding inequalities. We need to understand, and particularly we need also to understand what works for tackling inequalities. Okay, and so I'll leave you with words that are not mine, but I think they're still very actual. Of all the forms of inequality, injustice in health is the most shocking and the most inhumane. Thank you. Okay, thank you for your question, because this gives me the opportunity to show you something that I forgot to show you. And I think the answer is it's all in data use. If data are used, then the system will be sustainable. I mean, when we started in Italy, I was really very nervous the first 2 years, because the system was in a kind weak, because we were putting a lot of effort on the local health prevention department, asking mainly our nurses to do one interview per week. It's not a lot, but still it added to a lot of things that are day in, day out doing. So there was the effort, but there was no result at the beginning. Now, I don't think that anyone would like to stop the system, because they're using at a national level, but they're using also at local level. I've seen nice, working? Okay, yes. I've seen nice presentation done at local level using the data. And this is, for instance, just an example. Of course, it's in Italian, but just to show you what is produced on the single issue, because that's another important thing. When you release all the data, they're too much. But this is obesity. Obesity Day, we got the information. What kind of information? Well, maps. Maps are very useful to communicate. So you can get the differences among regions just in a glance. Then, well, you must show differences. Look at this, education, okay? And I should use this one. Let's go down. The other information, not only risk factor, awareness, and how GP are helping people and to perceive. Oh, and oh, this one is not okay. Here we are, and the trends. And the trends. This is geographical trends. So basically, it's a steady situation, but we have the north that is, again, those that were better are getting better, that is getting slightly better, and the south, that is a major problem in Italy, is steady over time. So this is part of information. If it's used, and typically what they do, this is a release that they can paste and copy in their program. This is a standard made at national level, but we do provide the tools at regional and also local level in order that they can play around with that easily. So again, the answer is sustainability. It's all in the data use and data communication. That's a big question, but in some way easy to answer, because this is part not of my merit. So I'm easy in answering, in a sense that that has happened before I came into the because in 2005 they had a trial of the system, and it was on voluntary based, and they were collecting data. They thought to collect data in perhaps 5-10 local health units. As you have seen, there are 200 in Italy. And 100 volunteered. And so the question is, why? The answer is they needed local data. They want their own data. And I think that's the key. That's the key. Point. So when we, and at that point I was involved, because I was skeptical about the use of non-technical interviewers. And instead, you have seen the performance, they're much better than the other ones. And of course, training is important. We have done very good training, but the involvement as part of the training was to answer why you should do that. Why you need to do that? Because you're part of the system. And so if being part of the action, you are also a key actor of the information, you will be capable of reading that information in a much better way. So it's part of your professional skill to listen to people. And this is a great opportunity. Every week, you have half an hour conversation with a person, with a real person of your territory. I mean, it's not someone that's calling from Montreal to in Vancouver. It's someone that is based and working in Montreal City, talking to a citizen of the Montreal City. That's the key. And of course, I do remember the first big meeting we had with, and we invited all the interviewers. So we were more than 100 people, 1,000 people. And the passion that was in this data collection. And that's the involvement, the personal involvement. That's the key, the personal involvement. And then when they see that they can use the data, these are my people. These are my people. Certainly that is an issue. So we worked a lot on the questionnaire just to avoid social desirability. So partially you work on the questionnaire and how questions are addressed. You work in the training of interviewers and on the little things that are perhaps do not compare on the data set, but are very important in the questionnaire. The words that are said at the beginning and in between one section and another one. But this is not enough, I agree with you. So we have done some validation study. And of course, we know that we are underestimating something. But in the surveillance system, the bias is not so important unless it's completely out. Okay, but for instance, let's take obesity. Okay, perhaps in South it's not. Oh, this is not obesity. This is overweight and obese. Otherwise, it was too high. It's 45%. Okay, 45%. Perhaps it's not 45. It's 48, because we know that particularly women tend to state a lower weight, and men tend to be taller than they are, to say they are taller than they are. So basically we are underestimating. But the information for action is not 45 against the actual one that is 48. It's not a big change, man. The information is, it's steady over time, or it's changing, or it has changed. So there are biases, of course, that must be taken into account, but still the information is there. Okay, let me start from the limit of a web-based surveillance system. The limit is it's all in selective participation, and at the moment, but things are changing rapidly. So at the moment it was unthinkable in Italy. When we started, it was unthinkable. 2007, the web was in only 20% of the household. So useless. But now it's changing rapidly. Certainly, we cannot think of going web like that in the future, in the present, sorry. But in the future, well, that's a serious possibility. That's a serious possibility because it's faster. Certainly, it's faster. Some way it could be less burden on the respondent, because take half an hour on the phone for someone is too bad. But instead, someone that is playing with Facebook 2 or 3 hours a day, well, half an hour is nothing, and answering questions. But well, that's a possibility. That's a possibility. It depends from the culture. I mean, the survey approach is just one approach for surveillance. The base of surveillance is not the survey. It's all what we have discussed. So I was telling this morning to students that in Kenya they had a nice trial of surveillance doing in a completely different way, and because they cannot do a telephone survey. But so It depends from the context. But that's, I believe that's the future. And in a few years, it will disappear. I can show you the response rate in the US. It's amazing. Man, it's certainly, we must think to something else in the future. There is someone that is thinking about that. Recently I had a meeting with WHO Europe, organized by WHO Europe, with some person that are thinking about this. I can tell you a very little story. I do not have the slide, but it's okay. Because after that meeting with a student of mine, we have tried to collect tweets and to address a health problem. And I've chosen as problem the electronic cigarettes, because we know that we don't have enough evidence, but still we are thinking that they do not help quitting smoking. So we have collected, and now she started in January 2000 this year, and now we have collected 5,000 tweets that were in some way linkable to electronic cigarette, okay? 4 months. Guess how many of these the word quitting smoking was in? Less than 5%. So these are data that are there, and we know that in marketing they're already using, I mean, the stocks of Facebook are so high just because they use the data they have. And so I think it is usable. Of course, there are a lot of problem of reliability and so forth, but still, that's easy information because it's there. It costs nothing. I mean, and it's there, and you can have information, particularly for public health campaign, for instance. If you want to see if after the campaign something is happening, well, Twitter, Facebook are very good information to understand if something is going on. And also in this case, I mean, I don't know if you are familiar, but you can see everywhere now word clouds in which they put the word, and the word is bigger if it's more used. Okay, there are this funny thing that you can also use on yourself and on your CV, what the words that are the keyword. So basically, we produced this kind of nice graphs, and the word, of course, the big word was, because we have chosen tweet with that word, the big word was electronic cigarette, and then a lot of other words, and quitting smoking was so tiny. Slightly more was health, but just slightly more. All the other was other thing.
There's a lot of noise.
Well, not noise. The evidence is that people that are using electronic cigarette think of other thing but health and quitting smoking. Sure. Actually, at the beginning, I'm a statistician, so I'm in relationship also with a colleague at the National Institute of Statistics. At the beginning, we were really attacked by the National Institute of Statistics, saying, we already have a system. They are not using our data. They do not use the data. And then here we come, and if you look at the local level, the data PASI data are everywhere. It's because it's not of relying, but first of all, the national system is not at the local level. So they can have only the regional one, okay? And that's the first reason why they are not using. But it's not a matter of relying on your own data. It's a matter of being attached. Okay, it's my data. These are my citizens. I have interviewed my citizen, and here they are. And in some way, I don't want to give you too much optimism. There are problems, of course, but I don't want to sell you a view that is too much optimistic. But it is true that health promotion in this way is counting slightly more in the local health unit. Because beside all the administrative data, all the hospital records and so forth, now they have also some data. So if you don't produce data, you don't count. That's very true in the system. So in the relationship, in the report that they produce every year, the local health unit, now they have also a section that is about risk behaviors and health promotion. Well, this is an achievement. Yes, we have a national coordinating group that meets every month, and I'm part of that, for all the technical issue. But 4 times a year, we meet also with the regions that are responsible for the PASI system. And usually we have half day specific on an issue. So we invite people from outside to talk about smoking, to talk about obesity, to talk about other important issues. And one day instead talking about the system. The first meeting of the year, we also talk about possible change to the questionnaire and possible additional modules. So to let time to have a subgroup working on that. And at the last meeting of the year, if there is a case, if there is validation about that, we together decide if there should be an additional module. And then the region are free to, beside of the core question, to add additional model and to choose among additional model, starting every January of the year. So if a region, for instance, is working on home injury, now we have developed a set of questions about home injury. But if a region is not working on that, they will not take that module, but another one. So it's flexible, and that's coming from the lesson that should be linked to action. So if in a region action is on something, there must be data information on that.
Dernière question. Thank you very much, Stefano.
Thank you. A pleasure. My pleasure. Thank you.